Hello everyone, welcome back to another challenging ECG quiz. This ECG belongs to a 72-year-old female patient who presented to emergency department with history of palpitations. She denies any history of chest pain and she is hemodynamically stable. Please follow systematic 7-step approach. You will get 10 seconds for each step. You can pause the video if you need more time. Please write down the answer. I will discuss the result in detail near the end. Let's get it started. I hope you have answered the questions correctly. Now let's discuss the each step and the correct answer. Step 1, heart rate. The rhythm is irregular, so to determine the heart rate, you need to count the number of QRS complexes on the rhythm strip. In this ECG, there are 16 QRS complexes. You need to multiply this number with number 6 to find out the heart rate. 16 times 6 equal to 96. So the heart rate is 96 beats per minute. The second step is finding out the rhythm. On closer inspection of the rhythm strip, a sawtooth pattern can be appreciated, which is characteristic of atrial flutter. In some leads, it appears as if P waves are visible, although they are not consistent. Overall, the findings suggest a combination of atrial fibrillation and atrial flutter, as these two arrhythmias may coexist. The third step is axis. There is a left axis deviation as QRS complexes are negative in lead AVF and upright in the lead 1. Step 4 is relationship between P waves and the QRS complexes. This is not relevant for this ECG. Step 5 is interval. PR interval is not relevant in this ECG. Checking for the QT interval using the online calculator mbcal.com and considering the heart rate of 96 beats per minute and the small boxes, corrected QT interval is 405 millisecond, which is within normal limits. Moving on to step 6, that is QRS complexes. The QRS complexes are broad, measuring approximately 3 small squares in width, which is equal to 0.12 milliseconds, which is equal to 0.12 seconds. Step 7 is STT changes. This is a T-wave inversion in leads 1 and AVL, ST segment elevation in leads V1 to V3, and an M-shaped pattern in leads V5 and V6. These ECG findings are characteristic of a left bundle branch block pattern. Final diagnosis is atrial fibrillation flutter with left bundle branch block. Tips and tricks for diagnosis left bundle branch block on ECG. Step 1. Think wide plus weird. QRS duration equal to or more than 120 millisecond, that is 3 small squares or more. This is the first clue. Always measure QRS complex width in leads with the clearest complexes. that is V1, V6 or lead 2. Step 2. Focus on leads V1 and V6. These are the bundle branch leads. V1 is the right chest lead. In left bundle branch block, you will often see a deep, wide, entirely negative QS or RS complex, that is no R wave or very small initial R wave. Lead V6, which is left chest lead. In left bundle branch block, you will see a broad, tall, monophasic R wave, sometimes notched M-shaped appearance. Mnemonic is William pattern, W shape in V1 and M shape in V6. Step 3. Look for absence of septal Q waves. In normal conduction, septal depolarization creates small Q waves in left-sided leads 1 AVL, B5 and V6. In left bundle branch block, septal Q waves are absent because activation moves right to left instead of left to right. Step 4. Check for the left axis deviation, which is sometimes present. Left bundle branch block may shift the axis leftward, but this is not a diagnostic criterion, just support you. Step 5. Check for discordant STT changes. In left bundle branch block, the ST segments and the T waves are usually opposite, discordant to the main QRS deflection. Example, deep S wave, we see ST elevation, T wave inversion. And if they are tall R wave, there are ST depression and T wave inversion. This is important when evaluating for ischemia. Use Iskar-Bossert criteria where there is concordant ST segment elevation of 1 millimeter or more for diagnosing myocardial infarction in the presence of left bundle branch block. Step 6. Use quick bedside mnemonic. William Marrow. Left bundle branch block is William, W in V1, M in V6. In right bundle branch block, that is Marrow, M pattern in V1 and W pattern in V6. Step 7. Don't miss these clinical pearls. New left bundle branch block in chest pain, treat as ST elevation MI equivalent unless proven otherwise. Chronic left bundle branch block is often due to underlying structural disease like ischemic heart disease, cardiomyopathy, or hypertension. Always interpret in the clinical context. Don't just stop at the ECG. Great job working through this ECG quiz on left bundle branch block. Remember the key points. A broad QRS complex greater than 120 millisecond. The classic M-shaped notched QRS in leads V5 and V6. Deep S wave in V1 to V3. And those discordant STT changes that can sometimes mimic ischemia. Left bundle branch block can be tricky, but with practice, you will spot these patterns quickly. If you enjoyed this quiz, don't forget to like the video, share it with your colleagues, subscribe to the channel for more ECG challenges. Thanks for watching. I will see you in the next quiz.